I'm sure I'm on now. Is my camera on, bro?
I can't see you, but perhaps you are visible, but please go ahead.
Okay. So yeah, I'll be sharing thoughts on priapism, and let's see. So just to introduce the topic itself.
Somehow now, sorry, Dr. Mandla, now I've messed things up for you. Now I'm seeing you, but I'm not seeing your slides.
I see. Let me try and rectify that.
Okay, there we go. That's better. Good. That's
okay.
Perfect.
Slides and video on.
Yes, thank you.
Perfect. Okay. My name is Mandla. Today I'll be looking at priapism. Certainly, clinical entirety I tend to see more often, more precisely because I tend to deal with emergencies currently where I work and where I've worked previously. And just to introduce the topic, priapism defined is a persistent erection of the penis that is not associated with sexual stimulation and or any desire of sex, and tends to last more than 4 hours as per definition. And this is a term that was derived from Priapus, the Greek god of fertility, gardening and last, and this is a term that has stayed with us since then. Unfortunately, the clinical entirety itself and management of it still remains an enigma and can be quite a challenge to treat. So what I've attempted to do with these slides, or with this talk rather, is to give a brief summary or the recent advice or treatment guidelines as depicted, or rather in the discussion that was held last year, November 2021, by the American Union Urology Association. And for the first time, they developed these guidelines together with the EUA, so it's combined, it's AUA and EUA. We'll remember the 2031, which were published by Dr. Mandla, revised again in 2010, were never combined, and certainly there's much changes based on those guidelines or those work that was done before, and mainly it will come to our surgical management of priapism, and also the phenomena of recurrent priapism. In terms of prevention, there's new thoughts on prevention of priapism in recurrent cases, and we'll basically look at the end on the thoughts now when it comes to prosthesis use in these patients. So I'll firstly use to guide the talk the actual guidelines, so that the reason I'm doing that is because priapism itself as an entirety still remains to lack evidence-based clinical guidance, simply because there's not much work done on it. There are no randomized controlled trials. It's most case control studies, opinion from experts. So I've got to say we use the guidelines because there's not vast or vast, what would you call, scientific knowledge behind it. So I'll give you a presentation and etiologies, different types of priapism. Ischemic being a persistent erection lasting more than 4 hours is defined, clinically manifested by both corporeals, rigid and hard and painful clinically, certainly anoxic, hypoxic with hypercapnia findings. Recurrent tends to be your priapism that is defined as ischemic, but with intermittent determiniscence in between. So the patient doesn't tend to develop anoxia, develop hypercapnia, or hypoxia of the corpora. It tends to have an intervening determiniscence in between. So that's the key defining feature between ischemic and recurrent. And your non-ischemic tends to be your high flow priapism, most clinically not in pain, not fully rigid, and certainly seen most of the time in the setting of background with someone with trauma, with arteriovenous fistulas. Then at the end, I'll speak briefly on management and outcomes of these patients. Yes. So the first 1 to 4 guideline statements when we came out of the November 2021 discussion looked simply at diagnosing priapism. So the first 4 guidelines just emphasize the point that the clinicians needs to be able to diagnose priapism. So with this next couple of slides, I want to take you through the clinical practice of diagnosing a priapism, being able to conclusively diagnose an ischemic versus a non-ischemic, and also knowing how to document, how to consent the patient, and how to safeguard your clinical practice not to miss things. So the first thing to do is the approach has never changed, is to look at etiology of priapism itself before you can diagnose it. So in most instances, it tends to happen on the background of medical diseases. Number one being your hematological diseases. We do know sickle cell anemia, especially that population group, tends to have a 42% chances that one will likely develop priapism, and it is certainly one of the key the population group we tend to see priapism in. And I can tell you now, I've certainly seen a fair share of those sickle cell patients presenting with priapism, whether recurrent or stuttering, or whether full-blown ischemic priapism. Then also oncology patients tend to have current, or rather present with priapism. Certainly following Dr. Muzi Lamidi's talk, penile CA is a risk factor, as one can see how an anatomical obstruction to your venous outflow of those dorsal veins in the penis can certainly predispose one to getting priapisms. Neurologic conditions can also put you at risk, spinal injuries or spinal disease, and obviously perineal, pelvic, or penile trauma, certainly putting you at risk of AV fistulas and hence risk of priapism. Infections and toxins have also been documented, and metabolic disorders, certainly. Then this is not an attempt is not rather all the drugs, but it is certainly gives you an idea of how much medications can put you at risk or be a cause of priapism. I've listed the different drug groups and with different examples of drugs that can put one at risk of priapism. So in diagnosing priapism, then knowing the etiology, knowing why one gets the disease, one can have an approach, decent approach to answer those treatment guidelines on how to diagnose priapism. And the approach hasn't changed. It's always history, physical examination, then investigations. So in history, it's usually very important to get the history of trauma, drug use, as we have seen from a previous slide. Multiple drugs puts one at risk of priapism. Knowing the medical conditions, as I've said, hemochromopathies, sickle cell anemias, any oncology underlying disease, and most importantly, history of the system of interest, any history of priapism, duration, degree of pain previously, and treatment that was successful. That's very important to know. And also key to know is whether a patient had existing erectile dysfunction, as well as the slide will illuminate later on. We tend to get patients with ED, go for ICI treatment, then get priapism. And the new guidelines give us good advice on how to manage those patients in order to reduce the chances of complications and erectile dysfunction. So in terms of investigations, I've got to say, and certainly in my short experience, history and physical examination is usually enough to delineate and to know whether someone is dealing with an ischemic or a non-ischemic, as one tends to be full rigid corpus with a spurred gland, quite painful, and one tends to be non-painful, and just from history and physical examination, one can make that clinical call. But if you still have doubt, investigations that are key to do is a full blood count, a differential count, HB, electrophoresis, toxicology, all in an attempt to first diagnose probable cause, and number two, to diagnose what do you call it, the type of priapism you're dealing with. And a corpora ABG is very critical and very crucial, as it will diagnose for you if you are dealing with acidotic, the pH of less than 7.25, hypercapnic with more than 65 mmHg of CO2, and hypoxic with a less than 40 mmHg of oxygen. In keeping with ischemic findings, then values greater than those will be diagnostic of your high flow non-ischemic priapism. They then suggest imaging as well, duplex ultrasonography if one is still in doubt, MRA studies. I've got to say I've never had to use them, and but certainly for academic purposes, with later slides I've given you pictures to try rather to confirm or show you how it looks on imaging. So this table is an attempt to summarize in a tabulated form your findings clinically to differentiate between ischemic, non-ischemic, and this table I've rather borrowed it from the work by Dr. Mandla from the 2021 treatment guidelines, and it tells you if it seldom happens, sometimes present, usually present, and then penile pain, as I've alluded to, will tend to be ischemic, and so on and so forth. And this will be the hallmark of I've given it a slide. The corpora ABG will be a hallmark of diagnosis, and should be documented in patient's file. We certainly do, and should be documented in patient's file, and patients should be counseled on the fact that ischemic does hold a high risk of erectile dysfunction, even with intervention, and proving it is ischemic, documenting it, prevents the later legal woes if patient comes back with erectile dysfunction and says, "Doctor, I was never counseled, and there was no documentation," certainly to the in-hospital stay or emergency management of the priapism. This is now on the left at duplex Doppler, post-traumatic high-flow priapism illustrated. I've never done one, and I'm yet to see one, but these images are borrowed from the reference work that's in my slides, just to demonstrate if one ABG is inconclusive, the history is not clear, which is usually very unlikely, but the duplex Doppler can be helpful. This on the right is in geography MRA of right cavernosa artery pseudoaneurysm, which is depicted there on the right. Also high flow priapism, certainly also work that is referenced on the slides. I've never seen one clinically on my clinical experience, but these are sort of all the other tricks or rather investigations we can certainly use to diagnose or to plan treatment, certainly in pseudoaneurysm if one is contemplating embolization of high flow priapism, which I go into in my later slides. So that's treatment guideline 1 to 4. Then treatment guideline 5 to 8 emphasizes changes in initial management of ischemic priapism. And the change here, colleagues, I want us to leave knowing what they've gone to emphasize is the fact that priapism occurring on an erectile dysfunction patient who's on ICI, intracorporal injections, presents to you with priapism. Phenylephrine should be the go-to treatment. You don't need to aspirate and irrigate. Certainly irrigation, you don't need to. You can aspirate up to 5 mL of clotted blood just to create space for your phenylephrine. Then phenylephrine though should be your first go-to treatment. They now advising against irrigation, the use of saline on someone you know is got erectile dysfunction, is on ICI, because what that does, it just predisposes the patient to later on erectile dysfunction that is permanent. So to answer the treatment guidelines 5 to 8, I've said enough about the first point there, and but the history that's critical to get from someone who's on ICI treatment is if they've started the use of other agents, or rather on their own decided to dose escalate treatment, which usually predisposes them to priapism. And certainly the trial of medical and oral medications such as pseudoephedrine, tebutelamide, beta-adrenergic agonist can be used. And if determinant is not achieved, then one should start to proceed to the priapism ischemic protocol. So this is one of the first changes from the work done by Dr. Mondieu in 2010. So this is important to note, colleagues. So then before I discuss the protocol itself, it is important to note any associated medical or underlying disease and seek early consultation from the treating specialist of the primary diagnosis. What do I mean by that? We certainly, because we are a quaternary hospital, our hematology unit calls us straight for these patients while they've admitted them to their unit. So we do co-management. Certainly one of the recent sickle cell patients I've had to deal with, while I'm dealing while I'm instituting rather my emergency management for the priapism, the hematologists themselves are giving the exchange transfusions, the oxygenation, the patient is on oxygenation, they are trying to alkalize patient, analgesia is given, patients are being hydrated. So it's co-management. At the same time, we no longer now say they must try these transfusion methods and oxygenation while we wait to see if they'll be successful. No, it is rather a combined approach, and you don't delay instituting the urological emergency treatment, which is aspiration, and it is installation of phenylephrine. And there's good documented work to say early intervention with phenylephrine PEP significantly increases the chances of resolution with intracavernosal use. So pre-surgical management of acute ischemic priapism is then dealt with guidelines 9 to 10. And with these couple of slides, I would just want to remind you how we do this, because one can't forget if it's not something you see every day. So the preferred agent is phenylephrine, which is a selective alpha-1 adrenergic. This is because it has less cardiovascular side effects compared to other sympathomimetics. Having said that, if one has access, it is always good to have these patients on at least a 3-lead ECG while you intervene, and cardiac monitoring continued. The mixture is phenylephrine 100 to 500 micrograms, doses suspended in 1 ml normal saline, and one can use a maximum dose of 2 milligrams. I certainly mix it myself. I've never had pharmacy assist me with that, but it's on their guidelines. Pharmacy should be part of this care so that we don't underdose or overdose patients. The dose is then administered 5 minutes apart, and then patient monitored for determinants. Most importantly, this is all intravenously, not subcutaneously. Important point to be made. Certainly in management, or rather, they felt it was critical to mention that in the last sitting of the association. So they also make a point to say this is administered laterally to the corpora at 3 and 9 o'clock near the base of the shaft. This is the anatomical landmark they felt the need to stress out and to remind us that that's where we should be administering. And I might be guilty here because I tend, on my clinical experience, to administer it through the glands into the corpora. And I'll tell you why at the end, why I usually tend to do that. But usually I go glaniocorporal to certainly aspirate and then certainly instill my phenylephrine. And this may be continued up to an hour, and they advocate the use of small needles. The particular point they're trying to make there is that the larger the needle or the bigger any puncture is made, the risk of erectile dysfunction increases. So they said consider penile block. I've got to say I don't consider them. I always start with the penile block and ensure that at least I manage pain locally, while the hematologist gives if the sickle cell anemia is giving analgesia IV or in whatever other form. Yeah. So the steps for the actual aspiration and irrigation is using a 16 to 18 gauge, 3 to 9 o'clock post-penile block performance. Then connect butterfly. Then you, with a Louis lock syringe, aspirate until dark clotted blood is no more, and you're getting fresh red frank blood. The reason for that, before you instill the phenylephrine, you can then the alpha receptors are then sensitized because the new fresh red blood is oxygenated and the receptors are sensitized. To give it while you're still getting dark clotted blood, resolution rates have been recorded to be rather low and it's not recommended. And this is repeated until 4 to 6 times until determinism has been achieved. So the quoted studies on the work that is referenced is that combination of aspiration with irrigation and the use of alpha-adrenergic receptors has shown quite good results. It demonstrated successful determinism in 71 to 93% of these cases, compared to as low as 43% alone if irrigation is used. So colleagues, we shouldn't just be irrigating patients, we shouldn't just be aspirating patients. Phenylephrine is certainly the way to go. And also reported post-treatment erectile dysfunction with overall, potency preservation is quite higher if phenylephrine is used and used early. This is just a picture to demonstrate the 9 o'clock rather here, 9 o'clock position. The 3 would have been on the right of where we aspirate, where the AUAC must aspirate. That's dark clotted blood. So you wouldn't yet instill phenylephrine. You would wait for red, fresh blood. Then the fourth tends to deal with surgical management from guidelines 11 to 14 of acute ischemic priapism. And to answer guidelines 11 to 14, I've prepared these slides for you. And this is where much change has happened, colleagues. This is where new things have come with the shunting procedures divided to distal corporoglandular shunts and to proximal shunts. And the message here is that the change is that with your distal shunts, which is your winter shunts, with the use of a true cut needle biopsy and algorep with a cross incision over the glands, ensuring that there's an excision made with the tunica albuginea so that there's communication. Erbehosh is the use of the scalpel blade on the glands into corpora to ensure and communicating channel. A T-shunt scalpel blade used with rotational movement. So the big change here is that they've attempted, it's a pity I don't have the graph. For you to download the graph, you need to be part of the association. So I couldn't have it, but they've demonstrated with the work done by Dr. Bennett, the American urologist, that for all your priapism presenting within 12 hours to 36 hours, there's about 30 to 40% of erectile dysfunction, and all those presenting more than 36 hours, there's almost 100% that they'll be erectile, they'll suffer erectile dysfunction as a consequence. This is because necrosis and fibrosis are set in. So what these distal shunts now and the new change tries to advise is that winter shunt can be used with the patients that present within the first 12 hours, as it can preserve potency. We just use a small true cut biopsy. There's not much injury to the tunica, whilst the algorep is rather used on the guy who presents, or a priapism patient who presents 36 hours or more. So that was a big change. And also added to that, once you've done your distal shunts and you still have priapism reoccurring or persisting, the big thing now they're introducing, which is also a change from the 2010 guidelines or treatment statements, is that we're now introducing the concept of tunneling. Tunneling So with the winter shunt or algorep, whichever, or Eberhard T-shunt as well, it can be used, where a dilator is used through glands into a corpora in order to dilate the channel and expel as much clotted blood one can. Obviously, this tends to be now with your patient who presents at 36 hours or more. As one could imagine, that the procedure tends to be very traumatic to the tunica, and chances of erectile dysfunction is 100% with the procedures themselves. Then we speak of proximal shunts. Before I share any word on them, I've got to say gray hair shunts, quickle shunts, all the proximal ones, it's certainly frowned upon now if one is ever in a situation to do them. The change with the tunneling alone has up to 100% achievement of determisence, never minding the complications thereof. So I don't imagine I, as a young upcoming or rather training urologist, will ever be in a position to perform a proximal shunt. So this is just a depiction, picture depiction of all the shunts we've just discussed. Top one being the winter shunt, in the middle the Eberhard, and the blade used there is the size 11 blade, and the T-shunt as well is demonstrated on the lower picture. I've spoken to the technique with the previous slide. This here is the T-shunt with intracavernosal tunneling. And I've never had to do one myself, but Dr. Louis, who's also part of that panel, who sat in the 2021 conference, is even advising that this tunneling procedure can be done in the rooms, in the emergency setting, provided the patient is given good penile block. Of all the distal shunts, the only one in my experience you have to take patients to theater is the algorep, but all the other ones can be done in our rooms in emergency. And the tunneling, he advocates, can be done outside theater. I think this is a game changer for us, simply because theater time can be scarce, and to be able to have a go-to procedure if your distal shunt fails. I think the tunneling is going to be a game changer. So this picture depicts a pre and post algorep procedure. We can see the black dotted necrotic changes there. That's just to show that tunneling was also attempted, and but it failed. So patient needed to be taken to theater for an algorep. Problems with the algorep, that scar tends to cause penile changes, glands deformity, but point being made here is that despite tunneling, sometimes you can have patients who then require a steel algorep or in-theater management. For the keen urologist, I said the proximals are now all in history, but it's very nice to know that the proximal procedures still exist or are still there, with the gray hair being basically the saphenous vein being anastomosed to tunica. How this is done, it is first mobilized, divided, like and tributary is ligated, and saphenous vein is spatulated to be joined to tunica. Problem with it, very high rates of thrombosis, pulmonary embolism, because one is operating on great vessel, or rather in saphenous vein, which is a tributary of the great vessels. This is the quercles, also now of historic interest, should not be used, but it tells how one can use the corpus cavernosum and shunt it to the spongiosum. Two techniques to do it. One could do it transcrotally and transperineally, with the openings placed in a staggered fashion. Could be done bilaterally or unilaterally. So complications is infections of the procedures, certainly also the distal shunts, and the use of prophylactic antibiotics. If you know you're going to shunt someone, especially cases that present after 36 hours, you should offer prophylaxis. And bleeding, patients should cancel the bleeding. There's a lot of bleeding, and certainly also from your shunt site. And with now certainly the introduction of tunneling, risk of urethral fistulas or urethral trauma is quite high, as one can picture the penis being a 3-cylindrical structure, 2 corporas on top, 1 spongiosum on the bottom. Very high risk you could injure it. So urethral fistulas are a problem, and wound breakdowns were noted as well. Penile deformity, especially with the algorithm, was documented with the referenced work that I'll show you at the end. And just a few words on penile prosthesis. Treatment guidelines 15 to 16 deals with it. Just to say there are no randomized controlled trials on it, but just to say, especially the EUA guys do recommend it. The grading of the evidence is grade B, and should be used in those who present after 36 hours. And the benefits there is that it relieves pain, preserves penile length, and return to sexual activity and overall satisfaction is better if done early. I think that's the only point to stress there, but it is noted it comes with high infectious rates. A few words on non-ischemic priapism. Remember, as I said in the first slides, always, or rather, one should be suspect in a background perineal trauma, cavernosal artery lacerations, but disease tends to resolve itself in about 60% of cases, with an approximately 5 to 30% of these cases complicating to erectile dysfunction. Important to note here, colleagues, with management of non-ischemic high flow priapism, irrigation and the use of phenylephrine is frowned upon. There's no role is seen. It's just a high risk situation. You're giving phenylephrine, potentially putting it in systemic, putting it systemically in a person via arterial flow. So advocate observation of these patients. Majority will resolve, and if they don't resolve and you really need to, really need to intervene, MRA can be employed in discussion with interventional radiology to use autologous clot or absorbable gels rather than coiling or any permanent embolization method. This is because they compared the temporal versus the permanent one, and in 74% resolution with 5% ED risk with temporal ones, while up to 39% erectile dysfunction with permanent material being used. For stuttering priapism, this is where most of the changes also were made in that last conference. And the key thing here to note is that we are now pushing for preventative rather than cure or waiting for priapism. So what that means is we're employing the use of hormonal agents, hormonal agents. There you are aiming rather to put patients at castrate level to prevent them getting priapism. And that's what we're aiming for. It's a very difficult clinical balance, because sometimes these are young patients, they still looking to have families or erections. So it becomes it's still a very technical thing to do. But that's the direction we're going. Certainly the use of ketoconazole was quoted at night to decrease priapism or erections recurrent at night. And they are also now advocating coaching of patients for intracavernosal self-injections of sympathomimetics at home to prevent recurrent or stuttering priapism. And early penile prosthesis is also being looked at for stuttering priapism. As a closing slide, colleagues, I won't keep you much longer. I want you, if there's something to take home, is this flow chart on how to deal and how to manage priapism. It's a recommendation. It's a guideline. As I've said, there are no randomized control trials. There's nothing concrete, but they just help us stick to a protocolized manner of management to yield successful results for patients. One can depart from them should the clinical scenario you're in require so, but it's usually nice then to document why you've departed from guidelines as they the only, or rather solely, what do you call it, best evidence we have currently. These are my reference for today's talk, and I'll certainly I'm open to opinion and advice as it is a topic that lacks very much evidence. Thank you, Prof.
Thank you, Masithemba. Nice comprehensive overview. Thank you. Congratulations for the work. I'm just seeing if there are any questions for the colleagues. I've learned quite a bit from you, Masithemba, in terms of the flowchart that we would use to go instead from a distal shunt to a proximal shunt, to go from a distal shunt to the tunneling. Can you just explain to us where that tunneling fits in? Is it something that you do up front? Is it something that you would do if the distal shunt is not working?
So with the tunneling, Prof, it's not upfront. The tunneling is only employed with failure of the distal shunt. So the distal shunt must have failed. And Dr. Louis, who's an advocate of the T shunt, also advocates that actually there should be 2 attempts with the distal shunt before one tunnels. And this tunneling, he says we can do it now in our office rooms or in emergency, and it's not a procedure that rather requires theater as opposed to the algorithm. So it's not upfront, colleagues. It is a failure of 2 times distal shunt.
I've always felt using a true cut needle is inadequate to create a fistula of sufficient size between the corpora and the sponge. And I felt that using a blade and doing a proper cruciate incision was much more effective. But they still seem to advocate the winter shunt.
Yes, Prof. They advocated, and the reason for that, Prof, is the work done by Dr. Pene, and he was able to illustrate to us that patients who present within the first 12 to 24 hours have 30% risk of permanent erectile dysfunction. Majority of those patients still can maintain the ability to have erections, and those who present 36 hours later have 100% erectile dysfunction. So I think we still advocate it because the idea is the trauma to the tunica and keeping the integrity of the corpora is better with the winter shunt, as Prof has illustrated that the injury is small, the puncture is small as compared to a blade. I think that's the reason, Prof.
Okay, no, thank you for explaining that. And one would imagine that the tunneling must be very destructive. Surely you're going to get very few salvages. You're going to have anything close to normal erections after that. I'm just trying to understand the rationale there, because you would imagine tunneling destroys all the erectile tissue.
I agree with you fully, Prof. So with the tunneling, patients who present, let's say, less than 36 hours, who you've done the winter shunt, they propose, in fact, it's even called the snake maneuver. They propose using a smaller dilator. But those who present 36 hours later, without you intervening, Prof, they already have 100% erectile dysfunction. They don't recover from the fibrotic changes in the phallus. So this is the work done by Prof. Pene. So the tunneling in those in that situation itself, yes, anyone you tunnel gets 100% erectile dysfunction post procedure. Very traumatic to the corpora, very traumatic to the tunica. But the idea is that the guy you are tunneling is a guy who presented 36 hours later, a guy with 100% erectile dysfunction. So the trauma, yes, there's infection, complication, higher rate. Yes, there's a bleeding complication, higher rate. But when it comes to the erectile dysfunction, it doesn't increase chances that you now erectile dysfunction because of the actual tunneling itself. And for my young colleagues, or certainly the ones in my level, this is where it becomes crucial, the documentation, which guideline 1 to 4 enforces, that record the timing of presentation and the risk of erectile dysfunction with late presentation and the risk associated with your intervention. Because a reason for that, and certainly I've got a very young career prof, but what we've seen is that certainly the patients who present post intracorporeal injections for ED tend to stay longer at home. They tend to believe it will go away, and they want it to resolve without coming back, and presentations tend to be very late.
One last question from my side, continuing to demonstrate my ignorance on this topic. You've enlightened me a lot, Masiteba, but people talk about using a pediatric BP cuff after you've done your shunt to continually pump it up and pump it down to improve your chance of success. Did you come across anything to support that idea?
I did not see it, Prof. Be honest, I did not see it, but I could imagine how it could work, because the manual, what do you call it, use of your own hand to pump the blood from the base of the penis out the distal strand is quite labor intensive, and hence one of the reasons we tend to go for theater early. This is a labor intensive process. I could see how that could be employed, but with all honesty, Prof, I did not see it.
Sure. Super. Masiteba, I'm not seeing any questions, so I think it just remains to thank you very much for your contribution this morning and wish everybody a good Friday.
Thank you very much. Enjoy, colleagues.